Maybe you have those citations or resources.
We can absolutely get those for you. Yes.
Sarah Nelson?
Yeah, thank you, Mr. Chairman. Do you see in any areas of federal government Medicaid reimbursement that we, if given some flexibility, could save money without affecting patients' care? Anything?
I don't think there's anything that helps us with a shortfall of the magnitude we're looking at right now. I think we can and should pursue vigorously those bundling, those avoidable rehospitalization, accountable care pilots. I think we need to be trying all of those things just as we need to try them across the whole healthcare system. I think the challenge is when we start looking at things like that, what we're talking about is reducing the rate of growth in these programs to where they're not growing faster than inflation, which is why we can't keep up with spending on it. And that doesn't help us with a $7.6 billion hole. And cost sharing, is within certain limits, particularly if you're talking about most of our seniors and adults with disabilities on Medicaid are living on SSI, which means they live on $700 a month. There's only so many co-payments that they're going to be able to come up with. So even if we do everything that we're allowed to do under federal law and co-payments, it will be a modest contribution towards the cost of our program. It will decrease utilization some, but it's not going to get us out of $7.6 billion hole.
Back to my question, though, do you see anything that if we were given some more flexibility from the federal government as a state that we could do things differently without having a negative impact on patients' health, but to do it more
I honestly think that there are not very many things that we don't already have the flexibility to do. The things that will truly save money, not just say no to people, as opposed to just saying, I'm not going to cover mental health, I'm not going to provide eyeglasses anymore, some of the things that we tried in 2003. I think the things that really change utilization and take-up, we probably already have the authority to do, and we just need to really aggressively pursue them. And I would say that this may be a failure of my imagination, and I'd be happy to work with your staff if there are specific ideas about the kinds of real service and delivery reforms that we want to pursue that aren't allowed under federal law, to work with you to figure out if there is a way to pursue them. But I think we have an awful lot of flexibility that we haven't utilized yet.
I'd like to interject here a second, because I'd like, at least as part of this discussion, to think about this a little bit differently. In Economics 101, it is taught that if you fix the price of a good or service and it's below the market value, you will create a scarcity. And that's what we run the risk of in Medicaid. If we lower the reimbursement rates in Medicaid, which are below the market value for that service, what will happen is nobody will provide it. There will be a scarcity. So one of the things that co-pays can do is to improve availability, because you no longer have to, because co-pays can help raise the price for that service, so you have more people willing to provide it. So as far as utilization is concerned, the reality is co-pays could, in some respects, increase utilization because there would be more people willing to provide the service. The second thing is, and your center just testified about this, about food stamps, and it recommended, where is she? Where'd she go? You recommended that we allow, when persons buying food stamps and paying for vegetables and fruits, to be able to pay cash in addition to that, what you called a voucher. It's the same idea, so that basically you get and you said that if you didn't allow them to use a little bit of cash to pay for fruits and vegetables, they can't fully utilize their benefit. So, Senator Nelson, I just want to think about it a little bit different. Fix the price below the market value of the service, you're going to create a scarcity. Co-payments can help eliminate that scarcity by increasing the value, the amount of money that service is being paid for.
So, Jewel.
Thank you. Are you advocating co-payments, or are you just bringing them into the discussion?
typically do not advocate co-payments, but since there's been so much discussion about them, I thought it made sense to acknowledge that we do have a lot of flexibility to pursue it. I frankly am not as rigid in my position against co-payments as a lot of healthcare advocates are. I think that if, and I'll be blunt with you, I think that if they increase the confidence of lawmakers in the program, that alone might be worth the experiment. And I think the difficulty is that the research has always shown that the one problem with co-payments is that people are just as likely to choose to forego something that's really medically necessary as they are to forego something that's not medically necessary, because people don't know, And so unless, and then we've also had the issue that providers are not always happy about having to collect them.
Well, that brings me to, as I talk to people throughout the country and go to the National Medicaid Congress, and even back when I was a resident in Pennsylvania 25 years ago, they instituted a $1 copay for office visits. And then the question was, are you going to turn away a mother with a sick kid with a fever over $1? The answer is no. Then you've got to put it on the books. You can't just write it off because it's a law and you're supposed to collect it. That's part of the deal. And then they said it was not cost effective. It cost more to put it on the books than the $1 was worth. Well, I'm sure that's worse now. I know it is because I run a medical practice. The other problem you have, members, is you have two types of providers out there that in an office setting you can refuse to see people if they can't pay, whether it's Medicaid paying a copay or private insurance or out-of-pocket uninsured people. You can't do that in an acute care setting such as a hospital emergency department. Now, they can turn people away, but then you run into malpractice issues. Is that person you turned away with heartburn really having a heart attack? So that the tendency is to, unless it's just so obvious that it's not a true urgent care, is to go on and see the folks. Then you've got putting it on the books again. I mean, that's...
And I should clarify, I think under EMTALA, it would be illegal to turn anyone away from the emergency room, no matter what kind of copayment they have, whether it's from Blue Cross or Medicaid. What you have to do is take care of the emergency and then give them the bill for the copayment they owe you. So it is, but it is intended to discourage people from and make them think twice about going to the ER for the earache or the flu. Or
but it's tough to, I mean, there's the business end of it, turning away somebody, but then there's also just the compassion. Who's going to turn away a year-old baby with a fever of 101? I mean, we run into that dilemma now in our practice, is that we're supposed to not see them if they don't have their Medicaid card. And you run into that, and I guess by legal rights we can, but at the same time, what do you do with a baby's got 101 fever, and you know them, they've been in the practice before, but you don't, you run the risk, you turn them away, you run the risk of a bad outcome. You don't want to happen to someone. If you take them and they've said they forgot their card, but maybe their eligibility's up, well, then you're trying to collect money. You have all of those factors. And again, there are different, depending on where you are, what type of provider you are, whether you're home health services or your equipment or your pharmacy or whatever, your risk of denying the service or your cost of putting it on the books and all of that are totally different. And those are...
I'm sure in your experience matches mine, which is over the years that I've worked on this issue, I've found Texas doctors very divided in their attitudes towards these co-payments. Some of them adamantly want to see them, and others adamantly don't want to have to be the ones who have to collect them. So it doesn't make your job easy in approaching that issue.
And I have people with jobs and have insurance who call up and want me to call in an antibiotic because I don't have the money to pay the copay, or they just want me to, which is not good medicine, to treat people over the phone. But that's not a phenomenon limited to low-income people or that type. They just, the blue-collar workers, the maintenance people at hospitals or school districts or defense contractors like we have in Greenville or Rubbermaid or whatever, these people are insured. But the copays and deductibles, they act like uninsured people because the copay is, when I say act like uninsured people, they delay treatment or they go to the emergency department where they can't be refused if they don't have their copay. We're in a primary care setting, they can be. I'm not saying it always happens, but it's always a dilemma for me having to make a payroll and meet my overhead when I have, as brought to my attention, that someone is sick but they can't afford their copay today.
I'm sure it adds to the complexity of running a medical practice.
And my agreement with health insurance companies, for the most part, is that I can't waive the copay. You know, that's part of the. If the office visit is $70 and the copay is $25, that means the insurance company's part of that is $45. If I waive the copay, meaning don't worry about it, you don't have to pay it, I have breached my contract. Because I am now all of a sudden, you talk about reducing fees or whatever, I'm now charging $45 for that office visit, when another insurance company or the same insurance company could say, well, you took $70 for that, but you only took $45 from them. So therefore, you could probably make your practice go, you know, this is how complicated there's all kinds of scenarios. The other question, I wanted to go back to the thing about WIC. I'm missing something with that program. Why is it that they lose some of their benefits if they don't have the ability to pay cash? What is that? What's in the system?
I would have to call Celia back up, and if you would like me to do that, I'll be happy to.
I'll just talk to you another time in the interest of time with the committee. But
I am not advised.
Okay.
I did want to mention for Senator Williams that there are a whole array of co-payments and enrollment fees in the CHIP program separately. It was created with broader ability to do that because it serves higher income families.
Is there a limit to the percent of that $700 a month in the case of disabled people that this SSI that they have to pay? And I've talked to various groups.
Federal government sets some limits, upper limits on Medicaid co-payments, and I think one of the things that changed with the Deficit Reduction Act was indexing those to inflation so that they don't stay a flat dollar amount that becomes meaningless after a few years. Yeah. So they have tried to set them at a level where they can't get out of hand for very low-income people, but there's some challenges in how you make sure they don't exceed a certain amount. You could imagine that a senior on SSI could have a lot of prescriptions, and if you had a lot of co-payments, that could conceivably add up.
Well, theoretically,
if
you had 700 visits in a month, and it was only $1, that's 100% of your income. I mean, do they set guidelines about the percent of your monthly income that you have to spend?
I remember, it's been a while since I've dug into the details of this. I do know that in Texas we talked about trying to make sure that it didn't exceed a certain percentage of the income, and that creating an administrative system for that in itself is another challenge.
Yeah. So. Okay. Thank you, Mr. Chairman.
Senator Lucio.
As we compare ourselves to other states in the Medicaid programs, let's say California, is there a difference, a major difference in Medicaid reimbursement for same type of procedures from doctors? Number one, and number two, why is that? And number two, are there in your studies, have you found any reason to doubt that some of these Medicaid patients are getting, in fact, too many tests being given them that drives the that obviously blemishes the account, the fund?
On your first question, Senator Lucio, one of the difficulties of understanding anything about state Medicaid programs is that each of the 50 states gets to set its own reimbursement rate and method for every single kind of health care provider, and there are essentially no minimum federal standards for them. So it's difficult to even get up-to-date comparative information from state to state, and typically we're lucky if we have a general sense of how we compare to other states for physicians, hospitals, and nursing homes, the big categories in there. Having said that, it is not always intuitive who's paying more and who's paying less. Historically, New York, which I believe consistently has the highest expenditure per Medicaid client, also has some of the very lowest provider payment rates. So it's not, again, always intuitive. I think the thing that's obvious about physician and other professional rates in Texas Medicaid is that we have not had any kind of regular inflation adjustment to those fees since around 1990. I think there have only been 2 increases to professional fees since 1990, and one of those we pretty much wiped out in 2003 with our cuts. Then we had some generous adjustments in 2007 as a result of the FRU corrective action plans. And my understanding is that if we were to take a 10% cut, it would not completely wipe out all the gains of 2007, but it would reduce quite a bit of them. So we are essentially are paying rates that the 2007 increases are essentially the only improvement over about where we were in 1990. And frankly, our rates weren't thrilling to doctors back then. But before, I want to say 1998, I think TMA has probably shared with you their surveys of physician and who's taking Medicaid and who isn't, and showed you how that percentage has dropped precipitously. And I believe that in 1998, 76% of doctors said they were taking new Medicaid patients, and now it's around 43%, which is up from the low that we had right before or right after 2003. So we have a challenge with our rates. I didn't get much further than Economics 101, but in one of my healthcare economics classes, the professor said, there's a question about how much profit folks should be making off of public programs, and it's something that economists debate about, but they shouldn't be losing money on them. So even
I forgot the question.
Sir.
I guess I got lost there. Okay.
Talking about difference in rates and also...
about the difference in rates. So, again, there are as many rates as there are states. There are states that pay a lot better than Texas does, and there are states that are playing closer to the Medicare rate, I would say. But it is a different comparison literally for every type of provider. So if there's specific things I can follow up with your staff on, I would love to help them track those down. In terms of overuse, there's no doubt that we are doing some things more than we need to. And one of the challenges, and I think that's true across every part of our healthcare system, and one of the challenges that always stops us from maybe getting to a better place with overutilization is that frequently you have to make some investment in care management and coordination in order to get to a place where you're not delivering a bunch of drugs that aren't helping or services that aren't improving people's health or tests that have already been done. And I think that our reluctance, unfortunately, to make those investments sometimes holds us back. I also think it's important to remember that one person's prudent utilization management is another person's rationing. And so we hit up against some people's very strong feelings about my doctor should be able to prescribe for me anything that he thinks is a good idea, and nobody else should be telling him what to do.
Any other questions?